Welcome and good day, everyone. Welcome to the Heal Me first workshop, which is on healthcare 4.0 technologies during challenging times, education, research, and future directions. I'm Professor Manish Kumar, Professor of Service Operations at Cardiff Business School, Cardiff University, UK, and I will be moderating this session today. We have got excellent program over the next 2 hours where excellent speakers from academia and industry to talk about how lean and healthcare 4.0 can be integrated or could be integrated. They will be sharing their examples from the research and from the application in the hospital environment. Share my screen and show you the agenda for the day and introduce you to our Heal Me research group. There you go. So first of all, we are part of this Heal Me Research Network, and HEAL stands for Healthcare Association for Lean and Management Excellence. We are a group of transnational multidisciplinary researcher, keen research, education, and the development and application of techniques and practices to improve processes through the use of methodologies from computer science, analytics and information technologies, operational research, operations management, and operational excellence, including Lean and Six Sigma. As you can see in our schedule, in our agenda today, first presentation from Professor Guilherme Tortorella in just minutes, which will be followed by practitioner, a clinician who has led Lean application in Argentina hospital, Dr. Sala. After Javier's presentation, we have got an interesting roundtable which focuses on healthcare 4.0 integration, how, where, and the future. In the first part of the roundtable, we have got two presenters, a short 10-minute presentation, each by Professor Tarcisio Rafael Aragon, looking into challenges, lessons, and future of implementing Lean in public hospital, and technology challenges to improve performance and patient experience. Thereafter, the floor will be open to the audience. We'll be addressing the audience questions. The panelists, the four panelists, which include Guilherme, Javier, Tarcisio, and Rafael, they'll be addressing some of the questions which you are going to ask in the next 2 hours. So I recommend you, I request you as well, listen to these presentation, enjoy this presentation, and keep posting your comments. We'll pick up your questions and we'll address it to the panelists and the speakers. So without any further ado, I would like to welcome our first speaker, Professor Guilherme Tortorella. Professor Guilherme Tortorella is a professor of industrial engineering at Melbourne School of Engineering, University of Melbourne. I would appreciate Guilherme, that thanks for joining us. It's 12 midnight there in Australia, and your eyes are still awake. You are keen to do improvements in the healthcare that clearly shows. And Guilherme has got 18 years of practical experience as a manager, as a consultant in metal mechanics, machine, and equipment industry. He has 100 papers in a highly ranked peer-reviewed journals, editor for operations management and production journal. Without ado, I would like to welcome Guilherme Tortorella.
Thanks, Manish. Thank you very much. I'm going to share my screen here. Hope you can see it. Okay, so first of all, It's a pleasure to be here and an honor to be sharing a little bit of our research findings in the past few years. And I came here to talk a little bit about the trends, challenges, and benefits of the healthcare 4.0, right? And our purpose with this research was to examine the implementation patterns, trends, challenges, and benefits from the integration of novel and disruptive information technologies into healthcare organizations. As you may know, Industry 4.0, also known as the fourth industrial revolution, is a hot topic nowadays in several industries. It is characterized by the level of interconnectivity, cyber physical systems, and also by a portfolio, a set of technologies such as IoT, big data, cloud computing, and so on. The versatility and pervasiveness of Industry 4.0 can be seen in several industry sectors and also in applications such as manufacturing, at our houses, smart cities is a hot topic, and also in healthcare organizations, right? However, the integration of digital technologies into healthcare is not a new thing. If we look up at the history, we're going to see that healthcare has benefited from the integration of new technologies since 1960s with the use of computers, especially regarding the medical data, to standardize and share medical data. And from then on, healthcare organizations have been incorporating more and more new technologies such as desktop, personal computers in the 70s and 80s, internet in the 90s, and there is this expectation that the healthcare industry is going to invest in the upcoming years more than $1 trillion in technology, right? So this is very promising, especially in the healthcare sector. Whenever we talk about healthcare 4.0, we are talking about an approach that allows us real-time customization of healthcare for patients, professionals, and caretakers. We are shifting from this hospital-centered perspective to a patient-centered organization. And the idea of these technologies also allows us to integrate different departments, roles, and responsibilities. Of course, these technologies became more feasible as the technologies became cheaper, their size reduced, and also the capacity of acquiring and managing large quantities of data increased. So this is quite a recent phenomenon. Also, we envision that healthcare 4.0 deserves or requires a technical change and reorganization so that those technologies can be adapted to social needs within the organization. And because of that, we may face some barriers imposed either by political and economic interests, demands from the organizations, associations, and lobbyists. So the point is that most of the studies so far, they have presented a narrow perspective of the application of these technologies. In our study here, actually, it had two main objectives. The first one was to identify and map those concepts that underpin healthcare 4.0. And the second one was to examine the effect of contingencies, contextual factors on such implementation, and also to verify how those contextual factors affect not only the technology's adoption, but also the barriers for technology for healthcare 4.0. So starting with the first one, we did this huge scoping study. We started with more than 22,000 publications, right? And we examined in the literature. We ended up with 78 publications, which allowed us to develop our study. In those publications, as you can see here in the bibliometric analysis, we can see here that the topic's really recent because before 2015, almost nothing was published in this regard. Also, we can see that the areas that have been researching healthcare 4.0 are also multidisciplinary areas, such as computing and information technology science, business and operations, medicine, electrical and mechanical engineering. So we have this mix of interests around this subject, right? Which is relevant because it is actually an interdisciplinary topic. This scoping review also allowed us to identify 9 main technologies that have been used in healthcare organizations. You can see that biomedical digital sensors, 3D printings, collaborative robots, IoT, machine learning, big data, cloud computing, augmented reality, and also remote control and monitoring. And whenever we analyze the application of those 9 technologies across the healthcare organizations, we can see that their pervasiveness is quite similar. Except of 3 technologies, almost all technologies are applicable to each and every process and treatment within the hospital. Also, in terms of barriers and challenges, this scoping review allowed us to identify something that we already had a feeling about it, that the poor infrastructure that we find in hospitals and healthcare organizations is still the main barrier for technology adoption. And also, of course, security risks, information security risks. So those are the 2 main barriers that the literature emphasizes as more critical for healthcare 4.0 adoption. In terms of the contributions and benefits from H 4.0, the main one that stood out was the use of technologies for the electronic health record systems, together with the usage of mobile health applications. So those 2 were the main benefits reported in the literature, and those are quite interesting applications. We also categorized those 9 technologies according to their roles, right? And in terms of role, we divided those technologies in communication, technologies that are supposed to communicate the data and the information, sensing, the technologies that are supposed to capture this data, acquire this data from products, patients, equipment, and so on. Processing technologies as the ones which transform this data into real information to support decision making, and actuation, the technologies that are gonna take this information and either control a software, control an equipment, and so on. So you can see here the emphasis that we found in the literature according to each of those technologies and the roles played within the healthcare organization. So you can see a fairly well-balanced distribution of the roles of those technologies in terms of communication, sensing, processing, and actuation. We also did this analysis of the application of those technologies according to each one of the value streams in a hospital. As you may know, a hospital, a healthcare organization is a very complex system, right? Which comprises several different flows, such as patients, materials, processes, medicines, consumables, information, and equipment. And we checked in the literature, we analyzed the literature according to the application of those 9 technologies in each one of those value streams. And you can also see here that those technologies can be applied, or we found evidence of such application in almost all, actually in all value streams, right? The emphasis varied a little bit, but we found successful results from those technologies integration. So what we found out from this initial scoping study is that there are 3 main opportunities for research in terms of healthcare 4.0. The first one is related with the systematic integration of healthcare 4.0 elements in healthcare organizations so that we can implement those technologies from a systematic approach, using a systematic approach and not isolated initiative. The second one was the influence of the contingency factors on healthcare 4.0 adoption, which is the research that I'm going to share in the following slides. And third, we also found that managing the social cultural factors to support healthcare 4.0 is a key issue, because most of the studies on healthcare technology adoption, they tend to focus on the technical aspects of such implementation and neglect the social cultural factors, the non-tangible factors such as behaviors, culture, learning, and so on. So there is this huge avenue for research in that regard. So moving to the second study that we did, and this one was a little bit larger because we did this huge cross-sectional survey to understand the effect of contingencies on the implementation of healthcare 4.0 technologies and barriers. We focused in emerging economies, this study. So as you know, emerging economies offer a unique context with particular challenges, and also some emerging economies such as China, Vietnam, India, Colombia, and Mexico, they have just reformed their health systems. So they are still evaluating and assessing new areas for improvement, if the routines, if the processes are okay, and so on. So this allows us to have a very rich scenario to build our case. The practical and societal implications of these technologies are still unknown in this scenario. And also there is the need to reinforce the development of disruptive approaches to healthcare delivery, especially in emerging economies. And of course, we're talking about emerging economies in which the social and economic context may be a challenge by itself. So the scarcity of resources, the scarcity of labor is also another variable that should be considered. And that's why we focused in emerging economies. For that, we surveyed 159 middle and senior managers from hospitals located in Brazil, India, Mexico, and Argentina. And we asked those respondents the adoption level of the technologies and also the criticality level of the associated barriers of healthcare 4.0. We also included in this survey a few contingencies. So we wanted to understand what was the kind of ownership of the hospital, private or public, the number of employees within the hospital, the functionality of the hospital. Are we talking about a teaching hospital or a non-teaching hospital? The age of the facilities of the hospital, and also the number of inpatient beds, right? So we did this huge survey. We analyzed the data based on some multivariate techniques, and we came out with this initial result, which showed that you can see that in red are the models that were significant. In other words, those are the variables, those are the contingencies that have a significant effect either on healthcare 4.0 technologies or in healthcare 4.0 barriers. So you can see that in terms of technologies, all 5 contingencies, all 5 factors, contextual factors, they do have a significant impact on technologies adoption. When we talk about barriers, only number of employees in teaching hospital or functionality of the hospital were significant. And let's talk a little bit more about each one of those factors in each case. First, considering just the kind of ownership of the hospital, right, and the technologies adoption. If we consider just this contextual factor, what we could see is that cloud computing was the only technology that we found significant results or significant differences between a public hospital and a private hospital. Surprisingly, the public hospitals indicated a higher level of adoption of cloud computing. And to explain this contradictory result, we had to look at the context, again, the emerging economic context. And for instance, in Brazil, 71% of the population seek care in public Brazilian hospitals. A similar number is found in Mexico regarding the healthcare capacity, right? In India, for instance, which is another country that we did our survey, only 5% of visits to healthcare practitioners are in private clinics or hospitals. So you can see the prominence and the relevance of public hospitals in those emerging economies. And since cloud computing generates healthcare statistics that usually are required by the controlling agents from the public healthcare systems, it makes kind of sense to have this technology more extensively adopted in public hospitals. Also because cloud computing allows the information from patients to be available in different stages of the healthcare process. So it's kind of reasonable to expect this result, however surprising it was. In terms of hospital age, we divided the sample between less than 20 years, the hospital that has less than 20 years, and hospitals that have more than 20 years, right? So we use this threshold to separate the sample. And in this case, what showed is that newer hospitals, as we supposed initially, they are more suitable environment for implementing healthcare 4.0 technologies. Whenever we are talking about age, we are using the age of the facility, the age of the hospital, as a proxy for the rate of or the openness for innovation, right? Because sometimes in the literature, age of a facility inversely impacts the rate of innovative improvements. Also, whenever we talk about older hospitals, we are saying that those hospitals are closer to what we call a brownfield. So we have this structure already segmented, we have routines, we have processes that are already established, and it kind of undermines the adoption of new processes, new technologies, new routines, right? Also, because these technologies are disruptive and they require this infrastructure to perform, older hospitals are less likely to have this established infrastructure to receive these technologies. So again, we found that it's kind of reasonable to understand or to expect that newer hospitals are more likely to have those technologies more extensively adopted, right? In terms of size of the hospitals, we used two variables to indicate the size of the hospital. The first one was the number of the employees in the hospital, and the second one was the number of inpatient beds. Regarding the number of employees, we found that hospitals that have a larger size, right, they are more likely to adopt a few technologies such as augmented reality, such as collaborative robots, right? And this is explained because larger hospitals usually they have more structure, they have more capital expenditure capacity, and they may also have a more availability of labor, skilled labor especially, right? Because we are talking about a more complex system. On the other hand, when we look at the number of beds, the smaller hospitals, the hospitals that had less than 150 beds in their facilities, they seem to adopt more biomedical digital sensors and IoT than larger hospitals, the ones that had more than 150 beds. And to explain this result, we associated this number of beds with the complexity of the hospital. So hospitals with lower number of beds display a more appropriate environment to healthcare 4.0 adoption with lower complexity. Finally, regarding teaching hospital, the functionality of the hospital, this was the most prominent contextual factor. As you can see here, 8 of the 9 technologies showed significant differences between non-teaching hospitals and teaching hospitals. And interestingly, the non-teaching hospitals, in all cases, they seem to present a higher adoption level of those technologies. As we know, teaching hospitals usually demand a more qualified medical staff and openness to learning, which increases the innovation level and attracts skilled employees. However, as teaching intensity increases, a larger number of inexperienced students will be inserted into the hospital. And this generates a lack of continuity and seasonal reduction in the expertise level of the workforce. So in other words, we are saying that this turnover that we have every year or every 4 years or wherever the frequency is, this kind of impairs a more extensive adoption of those technologies. So teaching hospitals, surprisingly, seem to show a lower level of adoption of H 4.0. Regarding the barriers, remember that we just found 2 contextual factors that were significant for barriers, right? And here in this table, a higher mean value indicates a less constrained perception. So, for instance, for hospitals with more than 2,000 people, regulatory changes seem to be less constraining in larger hospitals than in smaller hospitals. No significant difference was found for the criticality level of the other 7 barriers. In terms of teaching hospital, again, this variable was the most prominent one for barriers as well. And what we saw is that teaching hospitals, again, they are more constrained by all those, actually by 6 of those barriers that we listed here. So leaders from non-teaching hospitals feel less constrained by barriers. Teaching hospitals present a less favorable environment for healthcare 4.0, not only from the barrier perspective, but also from the technology adoption point of view. The overall conclusions that we got so far is that, first, healthcare 4.0 is a recent concept, and the knowledge on its implementation is still incipient, right? So there are plenty of things that we still need to understand and comprehend to better grasp this concept and have a more generalizable indication. Different environments, they do require different managerial actions to enable healthcare 4.0 adoption, such as we saw that, for instance, a teaching hospital, the approach that I use in a teaching hospital cannot be the same approach that I'm going to use in a non-teaching hospital. I need to customize and tailor my approach to the context in which I'm inserted. Despite the economic and social constraints in emerging economies, our findings pointed to several levels of healthcare 4.0 technology adoption in hospitals from those countries. So what we mean by that is, regardless the challenges that we have in economy, politics, social cultural factors, and so on, hospitals inserted in emerging economies, they can benefit from these technologies. It is feasible to have those technologies implemented in this kind of context, right? And also, our results demystify the assumption that the integration of new digital technologies into healthcare may be impaired by the socioeconomic constraints. So we are saying that this is possible regardless the context. Of course, we are not approaching here the difference between developed and emerging, but we are saying that it is possible to be obtained a reasonable level of adoption in the emerging economy context as well, right? The effect of the contingencies on barriers for healthcare 4.0 implementation is less pervasive than expected. So we saw that only 2 contextual factors out of 5 had significant effects, and out of those 2, mainly the functionality of the hospital was the main variable for the barriers, because the size of the hospital, we just found one technology, one barrier with significant differences, right? So the functionality of the hospital is the main one for the barriers to healthcare 4.0 adoption. When exclusively considering the adoption level of technologies, the contingencies play a more relevant and intriguing role, with some counterintuitive associations, such as the one that we found for between public and private organizations, right? We expected that private organizations, because they have more money, they have more capital expenditure capacity, they would be more prone to adopt these technologies. And what we found was the opposite, right? The identification of these technologies that are more likely to be extensively adopted in each context allows also the prioritization of managerial efforts. Because once I realize in which context I am inserted, I may be able to identify which technologies are more likely to be successful or more extensively adopted in my context, or which barriers I may concern first in order to overcome those barriers and anticipate some countermeasures, anticipate some actions that I need to do, because I'm pretty sure that I'm going to face those barriers sooner or later. They're going to come and I'll have to deal with them. Another thing that we believe from this research is that these findings, they may also help governments and health institutions and associations from emerging economies to develop strategic initiatives and foster the improvement of their healthcare systems. Once we realize which are the main contextual factors that affect technology integration into healthcare systems, governments and institutions, they can develop those initiatives in order to favor those technologies. And keep practical implications not only to hospitals, but also to society, because once we develop a more efficient health system, not only we benefit in terms of the organization, but also the societal implication, right? We provide health in a more effective way. Here are just some of the publications from our group, and you can see some of the findings that I shared with you today are already published, and so whoever has more interest, the publications are there, and we'll be happy to share with you. Thank you very much for your time. It's an honor to be here, and I hope you enjoyed. Thank you.
Thank you, Guilherme. That was an excellent presentation. A virtual round of applause for you. And thanks for painting the landscape of Industry 4.0 or Healthcare 4.0 technologies and how it is being applied both in public and private hospital settings, especially from the public sector perspective. We have got one question from the audience, Rafael Alves Ferreira, and he has asked you a question. Do you already have a defined scale or maturity model to assess the adoption level of healthcare 4.0 technologies?
No, we didn't develop that yet. This is a good opportunity, but we didn't reach that yet. We found some categorization of this adoption, such as we have empirically validated some constructs such as sensing and communication technologies and processing and actuation technologies, and we verified their impact on performance. But we didn't create scales such as a maturity model or a framework for such implementation.
Yeah. Could I just add to that? Is it a bit too early to even do the maturity assessment, given that it's quite an early stage of these adoption of these technologies in the healthcare setting? To talk about maturity. Interesting, Guilherme, in terms of you categorized these technologies for linked to communication, sensing, processing, and actuation. And look, it seems, is there any sort of like communication and sensing will lead to processing and actuation? Have you thought along those lines, how they may be linked to each other?
One of our studies, we identified the pathways for such implementation, and we identified that sensing and communication technology, they establish the basis for processing and actuation. So in a priority perspective, sensing and communication technology should be developed first, and then on top of it, we build the processing and actuation technologies.
Completely agree with you, Guilherme, given that the healthcare literature shows that communication is one of the biggest problem for healthcare errors. So if we build up, we use these technologies to improve on communication and sensing, it makes sense from there to move on to processing and actuation. Thank you very much for your time. You can relax now. You have done your job very well. Thank you. So on our list, now our second presenter is Dr. Javier Sala, who is a practitioner, who lives lean, who practice lean, who engage with their patients, who engage with staff, and who has helped hospitals to implement lean within Argentina. So Dr. Javier Sala, he's an adjunct CMO and CEO at Instituto Modelo de Cardiologia, Cordoba in Argentina. He's the founder of Lean Institute. Argentina is good to see a clinician leading lean initiative. It's great to see that. So we'll definitely welcome you here in UK as well, Javier Sala, to hear more about your experience. He leads the institutional lean transformation at the university, and he has been leading that since 2012. And Dr. Sala has been invited to lecture nationally and internationally about his approach to transform a healthcare organization. He organized the first Lean Healthcare Summit in Argentina that took place in 2018. He not only applies Lean, but he also has got more than 40 publications in this area. And he has been responsible for the implementation of Lean throughout the organization that has significantly added value to the patients. I can't wait any further to hear from Dr. Javier Sala about his experience of Lean in Argentinian hospital. Over to you. Thank you.
Thank you, Komar. Thank you very much. I'm going to share my screen. It's a pleasure for me to be here. Please let me know if you are able to see it.
Yes.
Okay, sounds great. So we are located here in Cordoba, Argentina. Our institution is called Instituto Modelo de Cardiologia. We're in the middle of the country, and we're actually an international center of excellence for the American College of Cardiology. So during my presentation, I'm going to talk a little bit about us, so you know what type of organization I'm talking about. What is our philosophy and values? We're going to talk a little bit about our achievements and differentiators, our lean journey. I'm going to show you some cases prior to COVID and then due to COVID. And during those cases presentations, I'm going to try to share with you some key learnings. So about us, we are committed to provide excellent patient care on prevention, education, and research. So this is a 44 years old institution that was actually built patient-centered. We have 53 medical specialties, although our name is cardiology. We started with cardiology, but then we started adding more specialties during the years, and now we have more than 53. Actually, you have 72 licensed beds, more than 8.7 thousand admissions per year. We receive almost 240,000 outpatient visits per year, and we have from those 57,000 are ER visits. We have more than 250 physicians, which 41 of them are cardiologists. And we do have a residency program in cardiology, which right now we have currently 30 residents in training. So our philosophy, which is very, very important for us, is that first comes the patient, second comes the patient, third comes the patient, and then the patient's family. This is very, very important for every physician and every personnel that wants to join our institution, that needs to know this, that this is our principal thing that we want everybody to share. And we are centered on doing personalized care. So our number one goal is improving patient care. Our values actually are very, very important also for everybody that wants to join the hospital. So teamwork and responsibility are very, very important to us. And we actually define responsibility to work with loyalty, with caution, with humility, with criterion. We define criterion, just answering one question: do what is best for the patient. Discipline, prudence, solidarity, commitment, management, self-criticism, very important, with humility. Communication, you just mentioned how important is communication in healthcare. Accountability, sense of belonging, and also respect and consideration. So just to name a few of our achievements and differentiators, our institution founded the first rehab center, and this is very important because we're going to talk about the rehab center during this presentation a lot. That was the first rehab center outside Buenos Aires in Argentina, and it was built in 1974. In 1977, we put our institution's first 2 coronary care ambulances, which were actually the first ones in Cordoba, in our state. In 1978, we started with our national and international scientific sessions. And in 1970s, we started publications for not only physicians, but also the community. We also held for many years a TV program where we also touch bases on CPR courses, also tobacco, stress, exercise, nutrition workshops, everything that could actually add value to our community. In 1988, we were the first ones in Argentina to do an angioplasty on an acute myocardial infarction in the country. So this was very, very important for us. We were pioneering this in our country. Actually, the first publication that came out supporting this technique was in the New England Medical Journal, was actually 5 years later than that. So actually, it was very, very important for us to be able to do that 5 years before. We actually were following a Kansas group from the US. So let's jump now to the 2012, when we started our lean journey. I was actually, I had lived in the States for almost 11 years, 12 years actually, and came back to Argentina and started working in the hospital on our lean journey. Since then, we actually looked into also acquiring accreditations from the quality institution here in Argentina. It's called ITAES. And in 2017, we actually applied a lot of lean to be able to accomplish our chest pain center accreditation that is actually given, at that time was given by the American College of Cardiology and also the American Heart Association. In 2018, we were the first institution accredited outside the US in heart failure by the American College of Cardiology. We're the first ones in Latin America to be able to be accredited into chest pains accreditation by the ACC and the American Heart Association. And there's only 5 institutions apart from us outside the US accredited by the ACC. And in 2019, we received the recognition as an International Center of Excellence by the American College of Cardiology, the first one outside the US with the new requirements. And actually at that same year, we actually received the recognition of the first place in the Quality Summit from the ACC for our work in heart failure. So let's talk about our lean journey and our continuous improvement here in the hospital. So like I mentioned before, we started in 2012, and the first important thing was to have the board buy-in. It was very important for me that the board supported this initiative. So we started with an evaluation of the institution, and we started assessing where were the leaders standing towards the future. So we started to add value by trying to improve patient experience and also waste reduction through different areas. So our strategic plan was to work on model cells. So we worked on the cardiac rehab program, and as I mentioned, we're going to talk about that example in this presentation. And we worked on other support areas like purchasing, secretaries, appointment centers, central lab, pharmacy, billing and maintenance departments, human resources, IT, administration. So you can see that we touch bases first on non-doctors, non-medical sites, so all the support areas first, except for the cardiac rehab where we did have a group of cardiologists working. It was very, very important key to work on leaders in company education. And by that, we actually had several experts visit us. We invited people from the States and also Switzerland and from Brazil to come work with us, do workshops and do Gemba walks with our leaders. We also did a very important dive into physicians leaders education. In 2016, a couple of physicians were with me. We traveled to the US, to the Ohio State University Academy for Excellence, and we were part of the cohort number 9, the first international group that were trained there in the academy. And after that, we actually brought in 2018 the academy to Latin America, and it was actually a great success. We had a lot of our physicians and non-physicians leaders trained in being in Six Sigma. It's very important for success to share your knowledge, of course. So we actually did the first Argentinian Healthcare Lean Summit in 2018, and since then we have been doing Lean Company in-company days where we share A3s, we do 5S workshops, Gemba walks, etc. So during this presentation, I want to touch bases on 5 cases. So the first one is actually our rehab cardiac center, which we actually applied Lean to transform it back in 2012, and I'm going to show you some results after that. Then due to COVID, we had to change a lot in the hospital for the last year. So we had to create a fever clinic. We had to work a lot on a staff exposure reduction, as we didn't know exactly what was going on with this new disease, the new virus. We had to work on hospital-wide protective personal equipment optimization, because we were able to see the movie from the Southern Hemisphere earlier, and we were seeing all the different challenges that the US and actually Europe were having with these supplies. And also it was very important for us to be able to narrow down the time from testing to results to be able to optimize patients' decision making. So I'm going to show you what we did in that regards. So this is actually a picture from the outside of the hospital, and we have 2 areas. So the main entrance to the main building is on the left, and you can see on the right a building, this square building that is actually what was dedicated to our rehab center. So that rehab center is actually this one that we're seeing right now here. This is the map of the rehab center. You have a patient entering the building, and we had an area dedicated to warm up, aerobics, adaptive exercise, and cool down. And then we had another area that was dedicated to basketball and volleyball for the patients to be able to enjoy also playing. But when we mapped the journey, we had that every 75 minutes, we had 16 patients coming in. And what they did is they had the vital controls and consultation with the cardiologists. After that, they started the aerobic sessions, the adaptive sessions, exercise. And then they went, saw the secretaries and left. And we understood by looking into this that the basketball court and the volleyball court was not being utilized. It was only used 3 hours per week. There was a lot of space dedicated to that, and there were no other activities at that time. So we decided to redesign the area and add value to it and add value to the patients. So what we did is actually we created a different layout. So the secretary got moved. You're seeing a picture right there on the bottom. And we created an area for patients to be able to have a sitting room. And we moved into this area our stress tests, physical therapy, and also oxygen consumption tests, which are very important for evaluating the sports patients and also the heart failure patients and some other important diseases like pulmonary disease. And the court where we had the basketball and volleyball court, we were able to redesign and have there in series the aerobics, adaptive exercise, and it actually ended up having a room for multiple use where we actually gave workshops to our patients. So this is actually the new design flow that we had for our patients, and that provided us a great opportunity for incrementing capacity and adding value to our patients. So these are some of the results after Lean was applied to be able to improve this area. So we, at the beginning in 2012, we had 137 patients coming in every month. We ended up in 2010 with 258, and actually that was actually 340 before we had to close it due to COVID. We increased the amount of hours by 62%, with the max capacity went from 192 patients to 408 patients. The cardiologists that were devoted to the area went down in hours dedicated to the area, and that didn't decrease the value. It actually added value. They were more keen to work with the patients one-to-one due to working in series. Gym professors' hours increased by 100%. We had to actually as we were working in the series, the two different rooms full with the professors. And the secretaries now were devoted more time, but actually this was also shared with physical therapy and also stress testing. And the important thing too is that we optimized the space that was dedicated to the rehab center from 388 square meters. We actually went down to 148. So you can see that all this was actually very important because we were able to increase capacity and add value to our patients. We had a patients list, a waiting list, and we were able to increase the amount of accessibility of our patients to our program. So COVID came. We all know about COVID. It has been, all over the world, a big issue. And on March 3rd in Argentina, we had the first confirmed case. On March 6th, we have in Cordoba the first confirmed case. On March 7th, the first confirmed death in Argentina. And Argentina went into quarantine in 2020 on March 19th. So, and we actually had the largest probably in the world quarantine, so something that actually affected us a lot. So March 20th, okay, we had to close our rehab center, and we needed to create a fever clinic. So we decided, why don't we turn the rehab center into a fever clinic? So we started mapping the flow for this now new fever clinic, and we started working on how will the patient flow be. How will the physicians, nurses, and biochemists flow be to be able to have more of a optimized time that they need to be there, crossing over with patients, or at least the least, and also the imaging and technicians flow, how they needed to work to be very efficient to acquire all the information that we needed. So as you can see, this rehab center got turned into offices and also patient rooms for COVID patients. We ended up having the lab also here and also X-ray facility inside the same center. We also worked on how to transport our patients from the fever clinic. As you can see here in the map, we have the fever clinic, and then we have the main hospital that was next to it that we saw in the previous picture. And we did several drills and Gemba walks, and we were able to realize that our beds were not able to turn around in the ramps. So we need to use the exit doors to be able to enter the facility. We also saw some points, pain points, to transport patients, because we usually had here a family from other patients that were in the hospital being hospitalized. So we had to work on protocols to be able to move our patients into the hospital for ICU or inpatient rooms and be able not to have in that transfer anything that would delay the transfer of the patient. We also worked on mapping and also did a lot of drills and Gemba walks to be able to improve our ICU inpatient wards transfer and also the transfer from the inpatient wards to home. So the key learnings of applying Lean for this adaptation from the rehab center into our fever clinic was that Lean has been invaluable to us, as it allowed our institution to dynamically adapt to COVID-19 demands since March 2020. We were able to turn the rehab center into a fever clinic in 1 week. The spaghetti diagrams, rapid improvement processes, Gemba walks, and drills allowed us to differentiate flows for patients, nurses, physicians, biochemists, and technicians. And via several PDCA cycles, we were able to improve safety and efficiency. Another, like I mentioned before, another case very important for us was the protection, the personal protective equipment, daily monitoring, and efficient use. And what happened here, and most, and we know in many, many hospitals around the world, was that once the pandemic was declared, there was a lot of fear. So what we saw here in March, when the quarantine was declared, is that we had a huge increase in the amount of usage. But contrary to that, we had a decrease in the volume of patients. So we had a decrease in outpatient visits by 26.5%. We had a 19 decrease in admissions and a 25% decrease in surgeries. That did in contrast with the consumption of PPEs. We actually had an increased consumption of PPEs in March. We had an increase by 10% in gowns and gloves by 40% almost, and 130% in masks. So that raised an alarm. So we did a 5-wise analysis. As we all know, this is actually very important to do a root cause analysis to obtain the many opportunities for improvement. As you can see here, we divided that challenge into the consumption increase and also to the purchasing over a challenge over time. So for the consumption increase, for example, that was due to the PCR results, for example, that lasted for a long time. I'm going to touch bases on that a little bit later. So this is the reason that because the PCR results were actually tested and were outsourced. The fear for contagion from the people, lack of knowledge of the ways of the correct protection, and lack of clarity on the way of protection actually was one of the major reasons why they were actually very scared. So we worked on different countermeasures, okay, to actually target those different opportunities. And we worked on learning fast to standardize. We worked on 5S, Kanban, visual monitoring of the inventories, and also the review of correct use of the PPE during daily huddles. And we did very many PDCA cycles to approach that. So during our literature review, we wanted to know the mode of contagion. We wanted to see the suitable PPE according to exposure to the COVID virus. We wanted to know the management of COVID-19 patients versus suspected COVID-19 patients, if that was different and we could do different things. We also worked on every procedure PPE standardization. So the procedures with or without sterilization had to have different PPEs. Whether you were close or in distant contact of patient, if we were for more time or less time exposed to these patients, and how we assign gowns based on quality, exposure, procedures. So for that, we worked, like I'm showing here, in 7 PDCA cycles. And what we did is actually for every department, okay, we were able to standardize on non-COVID patients and suspected patients versus COVID patients confirmed what type of PPEs were necessary on every different department, on every different case. We standardized using 5S, and we reviewed the PPE use according to the literature. We had to unlearn and relearn, okay, many things during the process. We actually started our own production here in the hospital of PPEs, and actually we did huddles in the pharmacy and patient areas. Kanban was very, very important to monitor inventories, and the visual monitoring was actually very important to us. And the control was actually done by many areas, but we had one that was dedicated, that was a pharmacy. So here we have an example of our boards of the daily visual monitoring of PPEs per patient, and here per service or department. So that actually was very, very important, because in March, I can show you here some results of all these initiatives that we did. We had numbers of 562 patients admitted. 2 of them actually were suspected for COVID-19. On April, we had less patients admitted because of the quarantine, and we had more suspected patients admitted. And the same thing happened in May and in June. But based on all the strategies that we actually put in place, we were able to reduce the gown consumption compared to March. In April, May, and June, even though we had a lot more patients suspected of COVID-19. The same thing happened with gloves, and the same thing happened with masks. So you can see how effective this was and how efficient we were being with more patients and a less consumption of protective personal equipment. So the key learnings were that lean approach allowed us to quickly monitor inventory and evaluate the correct use of PPE on a daily patient basis and prevented unnecessary utilization over time. The hospitals need to adopt lean culture in order to add value to patients, providers, the entire organization, and also payers. And lean culture is a driver to accomplish safe and better patient care and an efficient use of resources. It's a low-tech but very high impact. The third case I want to show you is how we worked on reducing patient staff touch points. This was very, very important. We didn't know how the virus was going to behave here, how contagious it was. So the least amount of exposure we had was very, very important. But that shouldn't be and should never be in decrease of quality. So what we actually did was, with the first patient we admitted suspected of COVID-19, we mapped and we actually took into account how many touch points we had with him. So who were the nursing, the fellows, the physician staff, the biochemists, the radiologists, also the cleaning personnel, and also the food service personnel, how many times they actually on average went in contact into the room of the patient. And we found out that on average, we had 23 touch points. This is actually on a suspected patient, actually, and it turned out that that patient was not a COVID patient. And you can see that all these times that we went in there, we also used a lot of PPEs. So we said, and we reduced this by 50% by looking into different countermeasures. And we said, okay, why don't we standardize every personal patient interaction? Why don't we unify as much as possible nursing and medication control schedules? For that, you needed to eliminate departmental silos behavior. You needed to coordinate activities between nurses, doctors, laboratory, kinesiologists, food services. You needed to coordinate the arrival of food with controls and medications, and you needed to coordinate and merge activities among professionals. So you need to coordinate staff physicians and consultant schedules, and also lab and X-rays define protocols and patient status to be able to know when exactly you needed to go in. So for these, we also use telemedicine to monitor patients when possible, and we did daily habits to proper plan the patient-staff interactions during the day. So, of course, we had to do many PDCA cycles. In this case, the first one actually was to reduce the amount of time, the amount of touch points. And you can see here in gray that we removed and combined them. And now things that were done by the food services were done by the nurse. The things that were done by the fellow now were done by the staff. So we were able, by doing 2 PDCA cycles, to decrease the amount of touch points to 9, from 9 to 11. So once we put that in place during April, we had an average of 11 touch points per day, maximum of 14. In May, 8.3, maximum of 12, and in June, 8.4, maximum of 13. And we're still are controlling that nowadays. So the keys for this sustainability were daily huddles, PPE Kanban visual control, that was done actually daily by pharmacy, and data review by the committee. So we had a crisis committee that actually was formed to create all these different process improvement initiatives. We review the data bi-weekly or with deviations. And right now, because we are very, I would say, standardized, we're doing it monthly. So the key learnings were for this project that teamwork using lean methodology, in this case PDCA cycles, contribute to eliminate silos and optimize care for our COVID-19 patients. Lean reduced the personal motion and overprocessing, resources transportation, and indirectly optimized the efficient use of critical PPE. And Lean was instrumental in significantly reducing staff exposure to patients with suspected COVID-19 without compromising quality at all. The last case I want to share with you is how we tackled the information availability challenge. It was very, very important to us to have the results of the test as soon as possible. So March 2020, a year ago, our current state was that the government decided that every PCR had to be centralized at a single laboratory, a state laboratory, and it will take between 24 to 72 hours to report the results. Our lab sent samples once per day to the central state lab. The results were recorded twice a day in an internal dashboard, and it was inaccessible to our physicians. The results were reported on our EMR in batches by the lab personnel. Communication to and among physicians occurred in series, which actually delayed decision-making even more. And the PCR results for suspected COVID-19 patients is crucial for making decisions, so we need to do something. So just to give you an example, if you had a PCR result delayed on a COVID-19 patient negative, and that ended up being negative, that patient had to be isolated for a long period of time. His family or her family had to be in quarantine until the result was available. And we actually were using PPE necessary every time we went in to see that patient. So we mapped the process, and what we actually found out that from the fever clinic to the patient results, our lead time was 3.5 to 5.5 days. So by looking into the process, we realized that we had a lot of opportunities for improvement. Like we said, we were sending only one shipment per day to the central lab. The central lab lasted between 24 to 72 hours. We were actually looking for those results twice a day. And then we had to work in series. So we said, there's a lot of room for improvement here, here, and here. So everywhere that you see here, this bomb, we had to improve it. So we said, okay, let's work on it. Why don't we work on being able to send to a private lab that had to be also authorized by the government. Once the government authorized that we were able to send this to a private lab, then we moved into sending 3 different shipments so that decreased the number of lots, and we were able to spread out during the day the shipments. We had a fast track contract with a private lab. We were working in 12 different cycles during the day, so 12 times every 2 hours, our lab personnel will retrieve information. So we were doing pull nor push. And also we work, our target was to work on an online database that will be accessed by the physicians on their mobile phone. So the first iteration was this type of board in the central lab where we had the cases visibility only for the lab personnel, which was important because we were calling them every day and every hour to see if they had the results. But they decided, it's not working. We need to work with Post-its, and this will be easier to move the patients between being positive to being still waiting for that result, or once they were negative to move into the other row. So we wanted to written, then Post-it, then written, and that was, like I said, the first iterations that were not working fast. We decided to go in the lab to work on a database to allow access to a historic also information. And that had better access to prior data, but still was not good enough. So we worked on another PCA cycle, and we said, let's move that to the cloud. But that cloud was only accessed by the lab technicians. So we said, well, let's move that to the computers of every physician's office. And that still was great, but most of the physicians sometimes, after they saw the patients, they will leave, but they will still have to connect with the family of the patients that, well, they were at home, they didn't have the access to the information. So we said, okay, well, let's send them an information with daily metrics through a push email, but still that had to be done, and it was not at the time that the physician wanted to access the information. So we ended up coming up with an application that was installed on the phones of every physician. Well, they will only put the ID of the patient, and it will come up in red if it was positive, in green if it was negative, or in white if it was still pending. So that increased 24/7 access for physicians and increased, of course, patient satisfaction in a very friendly way of accessing the information. So the key learning from this case was that lean culture facilitated access to information among professionals from different institutional areas, eliminated waste, overprocessing, waiting, and emotion, and added value to the patients and family members by reducing the time for decision making. Reduction in time to results decreased the amount of PPE usage in patients with suspected COVID-19, which is very, very important. And the most important thing is to mention that all the improvements depended on more on teamwork than on a financial investment. So just to finalize my presentation, I would like to share this phrase that actually sounds that it's very, very new. The best way to predict the future is to create it, but actually it was said more than 150 years ago by Abraham Lincoln. So thank you very much for your attention, and I'm looking forward to any questions I may answer.
Thank you, Dr. Sala. That was an excellent presentation. I can see you live and breathe continuous improvement and some of the excellent examples how you managed to still practice the principles of lean. In fact, you managed to utilize a lean philosophy, lean culture, lean mindset in tackling COVID situation. So just a quick one short as a quick question and a short answer to that. Maybe we can revisit that question in the roundtable as well from Flavio. What are the recommendations to motivate the hospital staff, particularly the physicians, to enroll in lean activities given their usually high workload and especially when they were stretched too much during the COVID time? So how did they manage to still continue following the philosophy?
Okay, so I think it's a very, very interesting question that we have to target that here. So physicians usually think that it's very, very important to know about medicine. So, I'm a physician, I'm a cardiologist, I'm always looking into what type of disease, what new devices are available, what type of treatments are available. And we do not value the very important thing that Lean can add you is how can you actually improve your care of your patient by working on processes. So we actually showed that here and actually took our physicians to other institutions that were working on that to be able to share with them experience of other people. So one of the very important things is do Gemba walks. Either you go visit or invite some expert to come show your results. So get some other experts that are physicians, because usually physicians will listen more to physicians, okay? And that will be probably a very good advice, okay, to give to these challenges that you have in these hospitals.
Thank you. Thank you very much. Round of virtual applause to you for your excellent presentation. Thank you. Now we move on to the next session, which is a roundtable. And the roundtable focuses on Lean and Healthcare 4.0 integration, how, where, and the future. We'll have a short presentation from two speakers. First, by Professor Tarcisio Sorin, looking into challenges, lessons, and future of implementing Lean in a public hospital. Professor Tarcisio, he is the Professor of Industrial Engineering Department in University of Federal do Rio Grande do Sul in Brazil. He has got background in civil engineering, MSc in construction management, and PhD in industrial engineering. His main area of interests are related to modeling and management of complex socio-technical systems, lean production, resilience engineering, and safety management. And he has carried out research and consulting projects on these topics, mostly in healthcare, construction, and manufacturing industries. So without any further ado, I'd like to invite CCO for his presentation. Thank you.
Okay, thanks, Manish. First, I'd like to thank the organizers for the invitation to deliver this talk. I'm gonna share my screen. Okay, just a moment. Can you see my slides?
Yes.
Yes. I'll just try to change my slide. Can you see the next slide?
If you can go into the if you can go into the presentation mode, that's issue.
I think.
You are? Yeah, great.
What about now?
Doesn't look
Can I
like
go?
you can try again. It doesn't look like it has gone into the presentation mode yet. We'll revisit some of the questions which has been posted during the roundtable. At the end of the roundtable, we'll revisit some of those questions.
What about now, Manish?
Yes.
Can you see my slide, my title slide?
Yes.
Okay. So the title of my presentation is Lean Healthcare, Interventions Informed by Complexity Theory in a Public Hospital. Actually, I'm going to talk about our collaboration with our university hospital. Just to check, I'm now on the second slide. Can you see the pictures from the hospital?
No, Tarcisio, the slide is not moving. Yep, I can see that now. Yep.
Okay, it's not. Okay, so our studies have been conducted in our teaching hospital, which is called Hospital de Clínicas de Porto Alegre. It's a large hospital. It has about 6,000 employees, about 900 inpatient beds. It's the only public and teaching hospital in Brazil which has an accreditation from the Joint Commission. They don't have actually a formal Lean program. As most hospitals, they have a kind of fragmented and isolated improvement initiatives. But in 2014, there was an important milestone in their improvement journey. Myself and colleagues, Guilherme, who is here, Flavio, who is in the audience also, and some colleagues, we offered a specialization course on industrial engineering to 30 employees from the hospital, picked by top management. These employees were in charge of learning industrial engineering techniques, for example, Lean tools and theory, and to apply these theories and tools in their processes. So we have been working with this hospital for 7 or 8 years, and based on that specialization course, several collaborative improvements have been carried out. On this slide, I listed some of my reflections during this period regarding some implications of applying improvement tools in public and teaching hospitals. This is not data collected from interviews, it's just my impression. Firstly, I think it's important to make it clear that they play a role in the broader public healthcare network. So they have drawbacks arising from that. For example, they have limited autonomy to set priorities and manage patient flows. Sometimes they have to do what's best for the network instead of what's best for them. This is a drawback, so that's why this is in red on this slide. On the other hand, they have it's probably easier for them to share resources with other public hospitals. I mean, for example, sharing equipment, sharing supplies, sharing staff. So the public network really works as a network, and this is a major difference in relation to the private network in Brazil. Well, other drawbacks in red on this slide also, they have a high turnover of residents and students. Guilherme also mentioned this in his presentation. They have strict hierarchies between professional categories. For example, on the top, there are the physicians who are also professors. A level below, there are those who are only physicians, and so on. And so they realize they are quite aware, I think, that this poses barriers to collaboration. Another drawback, also mentioned by Guilherme, is that public hospitals, they usually have a lower availability of financial resources, even though our university hospital is a kind of exception, because they are allowed by law to provide care to private patients as well. It's a small portion, about 10% of their patients are private, but this helps them a lot in financial terms. Other implications, which I put it in yellow because they have mixed implications. Making money is not a goal as important as it is for private hospitals. Of course, from the negative side, they are not making so much money. But on the other hand, they are less exposed to production and efficiency pressures. And finally, by the nature of being a teaching hospital, they are in generally open for experimentation and trying new ideas. But on the other hand, because of the bureaucracy, because of the lack of a robust lean management system, it's difficult to standardize and sustain improvements. Well, and as I mentioned in the title of my presentation, I have been working with them using complexity theory jointly with lean production. Why complexity theory? First, of course, because healthcare services are highly complex. They are, we cannot make direct comparisons between healthcare services and, for example, car manufacturers. So there are plenty of trade-offs, especially between safety and efficiency, a high likelihood of unintended consequences, a wide gap between work as imagined and work as done, uncertainty, influences from the external environment, which includes the political and social external environment. And also complexity theory emphasizes the role of resilient performance for coping with variability. And this is very important in complex systems in general, because in truly complex systems, people cannot follow standardized operating procedures all the time. So it will be unavoidable to fill gaps in procedures and many times to improvise due to the lack of resources.
CC, just a quick one, just an improvisation may be required here as well. We are short of time, so if you can share some of the key lessons that you have got to share with the audience here, please.
Okay. So I will just mention one of the projects we carried out with them, which is related to Kaizen projects in the preparation and administration of medications. As part of that specialization course, we developed a value stream map of the process of preparation and administration of medications. And this value stream map gave rise to several Kaizen projects. The main Kaizen project, the most impactful, was related to the use of the automated dispensing cabinets. This, you can see a picture of them here. They had a peak of demand around 8 a.m. in the morning. This graph on the bottom of this slide shows the distribution of the demand according to the times of the day. And only because of that, they needed 2 sets of automated dispensing cabinets. So the changes that were implemented involving changing the prescription time of some drugs and removing some supplies from the cabinets, which weren't really necessary to be stored in there. So based on that, they were able to release one of the cabinets and send them to another unit in which there was no such equipment. But there was also an interesting theoretical insight from this project, which related to the fact that not all Kaizen projects worked in synergy. For example, on the one hand, they did some ergonomic improvements in the use of the cabinets in terms of changing the positioning of the supplies inside the cabinets. So this reduced the workload of employees. And on the other hand, in another Kaizen project, they installed patient dashboards in some nursing units. And those patient dashboards were perceived by employees as increasing workload because they indicated through warning lights to very quickly the need for action from the employees. So they felt a little bit stressed because of that. So just to finalize, my theoretical insight from this study was that we realized that Kaizen is not really necessarily like a step function, like it's traditionally shown on Lean textbooks. Kaizen looks like more frequently as the picture on the bottom of this slide. So there are trade-offs, and sometimes not all projects help each other. So that's it. Thank you. I had another example, but I know I'm short of time.
Thank you very much, Tarcisio. Thanks for improvising and cutting the presentation short. And we'll definitely hear from you about FRAM, because that's the part of resilient engineering, and that's really applicable in healthcare settings. So maybe we are planning our future work that itself, that we'll have an opportunity to share that. Thank you very much for your contribution. So our second speaker in this roundtable is Aragon. He's got Masters in Engineering. He's a strategic planning and management control of the Austral University Hospital in Argentina. Innovation Center, the Hive of Austral University. And since 2003, he has been working in health with experience as general manager in other health institutions in Argentina. Rafael, for the presentation. Thank you.
Hello, thank you for the invitation to this webinar. It's a pleasure for me to be here with you. I want to first introduce who we are, the hospital, in a brief presentation. Let's share the.
Audience, keep please posting your questions. We'll address those questions. There are some questions still needs to be addressed, which we'll do after Rafael's presentation. So please continue your questions for our panelist here. Rafael, are you sharing your screen?
You see the screen?
Yes.
Let me put in presentation mode. Now you see.
Yes, thank you.
Okay, first I want to present who we are, the Hospital Universitario Austral, that is in Buenos Aires, 50 kilometers from the center of the Ciudad de Buenos Aires. I am talking from here, from the 4th floor of the hospital. The vision of the hospital is to be recognized as a school of professional and human training that combine the best and able to generate in our students a lifelong footprint, a referral center for the local and the regional community, to be promoters of the person's dignity, the life and truth for the entire society, to be an institution of election for health professionals, and to be leaders in innovation, knowledge generation, and technological development. The hospital is inside the Universidad Austral, that has an education branch and a health branch. In the health, we have the hospital and a prepaid plan inside the hospital. We are 3,000 people working in the hospitals, in physicians, nurses, auxiliary and technicians, and other personnel working. This is the size of our organization, to know what we are talking about. We have the central hospital, as I tell you, 50 kilometers from the Buenos Aires city, and we have 5 outpatient centers near the central building, more or less 10 and between 10 and 15 kilometers from the main building. We have cooperation agreements with several hospitals, and we are part of an alliance, a Latin American alliance, with the Albert Einstein, la Clínica Alemana de Chile, la Fundación San José de Bogotá, that we work together in several projects. Our size and the inpatient or the hospitalization is 220 beds with a length of stay of 5 days and an 85 occupation rate. We have 30,000 people in this church per year. This is the outpatient size with 136 outpatient offices. Okay, now that is what you to know what is our size, our complexity. We are a high complexity hospital, but we also attend our community near us. But let's talk about technology challenges. That is what is our staff today. So one of the first challenges was in the pandemic scenario, was to analyze what the organization needs in this scenario, what are the priorities, and how much time we have to bring a solution on what options we have for each need. So it was clear that we don't have enough time to analyze the better solution with a long-range perspective. Our 3 or 4 years perspective was transformed in a 3 or 4 weeks perspective, so we have to bring solution faster than previously. We have to analyze each need with 4 different perspectives. Patient and family first, professionals that have to change the way he work, payers, and the internal users and the organization inside. So let's approach each of perspective and what are the needs of that perspective. If we put in the patient's perspective, they need to continue their treatment safely. They need advice and secure information. They want to get virtual attention. They don't want to go to the main hospital because of they was afraid of the pandemic, and they want to have a self-management of his record and his studies and all that stuff. Okay, and we have to take this in first place, because if not, we are getting in trouble. But also we have the professional perspective that they need training. They don't use the tools that we have to share. They need connectivity in their houses and in the places where they are. Modern tools. We are a hospital that we born in the year 2000, and we born with an electronic healthcare record. That it was a big gain in our born, but they have all passed 20 years with that electronic health record, and we are now planning the change of that electronic health record. And they ask for modern tools for solve the problems. And the ongoing relationship with the patient. They want to need to be easy to communicate with their patients. All the way, the payer's perspective needs different things. Needs security in the services of the affiliates, new rules of services, reliable systems in the transmission of information, and eliminate papers. They want to virtualize all what we can. The users, the inside perspective, they need containment because they also might be afraid of this pandemic. They need also training. They need also connectivity and portability because more of them work outside the hospital, and they also need modern tools. So those are all perspectives that we have to take in count when we bring solutions. What we have done, some of them, obviously the telehealth visits was one of the big wins and the first wins with more than 10,000 of virtual visits per month. Now I want to show you what the evolution of that telehealth. It represents more or less the 15% of the total outpatient attendance. Auto admission in the in-person visits, all the visits that is in the hospital or in the ambulatory places, although the emergency department has been attended with an auto admission with the cellular phones or mobile applications, reducing the time and the contact. 75 is 85 virtual. Now we're going to be the graph. 85 of the virtual admission in the emergency department we are reached in the last month. What we have done also, this is a big part, and I'm going to show a little presentation of that. That is, we create 2 years ago an innovation lab, an innovation ecosystem for creation new solutions to bring all the sectors in this ecosystem to bring new solutions to the healthcare. And that creation of the Hive, that is the open innovation ecosystem, it was a great place to look for solutions from providers, from the public sector, from any other industry that can bring solutions to us. Now I'm going to talk about that. But let's see quickly how the outpatient visits can be resolved with telehealth visits. As you say, in March, we here start the first case. The April was the month with more closed in all the society, and when they start the virtual visits, that is the red block, represent the 20% in April, and they continue growing the in-person visits, but the virtual visits sustain in 12-13% of the total consultant. That is more or less 8,000, 9,000 of visits per month, even now that it's practically normally the circulation. In the emergency, that percent is it's lower, with 3 or 4% of emergency virtual visits. Okay. How I say, the remote admission was one of the great gains. Then we have 33,000 people admitted in remote admission. It is 85%. That is with applications in the mobile phone. And let me show what is a brief story of the Hive. We don't have more time, but it's important to know what we are doing here before we can share the conclusions of these things. The Hive is an ecosystem of applied innovation designed to provide the ideal space for the co-creation of sustainable value, transforming existing health systems in an open, transparent, and collaborative way. The reason why create the Hive, because what is the reality of the healthcare worldwide? before pandemic also is that our healthcare business model agonizes. The more demand for services, more population, more older population, more sicker, more cost, and less professionals. So we have to do something. Before pandemic, we think this, and in pandemics, it's a great opportunity to bring it to bring it bigger. We don't take action. If we don't take action, the system dies, and us with it. So our main objective into care is to care people health. The goal is being lost. You see all the problems that we have nowadays with the bad practices, with the old medicine, if we don't help with different tools. So, what do you think? That we have to adapt, to reinvent, and to get ahead, to change the model before we lose it. What is the solution? An innovate co-creation transforms ourselves to transform the sector. Join efforts and work towards a common goal, adding value in a sustainable way. We offer a unique proposal as a national and regional level where all health sectors can work together in an academic, transparent, and neutral environment. How is conform these ecosystems? Hospital Austral, we have a technological part with enterprises living here in our space, the hospital where we are, all the business school, the IAE business school that is part of the university, and all the graduate school. That's why we think that this ecosystem here we can help to make that ecosystem of co-creation. This is a validated model because several hospital organizations have this type of organization that's help us to the IT sector to bring solutions and to co-create together solutions for the new needs. So with a clear vision, a neutral position, and a defined mindset, that is why we can make it the difference. Our mission to lead the transformation for the healthcare system and its experience, contributing to the world and a sustainable innovation model focused on adding value to users. They have business units, an innovation lab, an accelerator lab to make bigger startups, a smart tank where we share knowledge, and a workspace where we share spaces together. We dream big. We are working with all of these technologies in these labs, with different labs. Some of them are recently starting, and the other ones have one or 2 years. But this is all brand new. So, what is our see of the new perspective in technology challenge? First, understand that the first change had to be our response speed. We have to respond quickly, but we have to be prepared because we have to implement, analyze, and change again and again because the speed often makes that we try several solutions that then when there are solutions that are more stronger and then more interoperability with the other systems, we have to change them. But first, we have to make solutions that can be tried for the users and the patients, and they are now, and the changes in the changing model, it's now. Involve new actors. We think that in our process that help us understand the context, we have to involve new actors. Already, the patient and the family, the public sector, the other enterprises of technology, telcos, and the rest. We have to grow in external relations. We don't have to work alone. We have to grow with others, with sharing experiences and sharing solutions. Share experience, that's what I'm saying, because we can go more secure and more affordable if we do things together, and get better management reports for senior management. We have to use the information to make better decisions, to make better solutions to the system. Thank you very much. and I stay here for.
Thank you, Rafael. So we have ended both the presentation. Thank you, Rafael. Again, an excellent presentation. You all, the four speakers, you have reinforced the importance of communication, cross-functional team collaboration, which helps to improve visibility. Now, there are some questions which I would like to present to the speakers, to the panelists here. Let me scroll quickly and ask one of the questions, which was from Luis de Souza for Sala. So if you can address this, how deep is the involvement from physicians to standardize procedures, and what are in the process? You can be short. The challenge or to allow physicians to follow the standard processes. So how deep is their involvement?
So here in our hospital, the involvement of the physicians is very, very deep. Okay, so we actually worked with training leaders. So for example, the chief of the ICU, the chief of heart failure, chief of the cath lab, the chief of the OR, all of them have been trained in the Academy for Excellence in Healthcare. So the involvement of physicians in leading all these process improvement areas have been key. Okay, so in our case, we have involved a lot of physicians in as much as we can, okay, to be able to be successful. And also that actually shows for the rest of their department how important it is for them to get involved too.
Thank you. Rafael, how has been your experience in case of the innovation that you talked about, engaging the physicians and clinicians to adopt those technologies? Rafael has dropped out, looks like. Connection issue, maybe. Okay, no worries. Let me move on to the next set of questions, which I would like our academic colleagues to answer. The first one is from Flavio. We have got experience of what is your experience in public and private hospitals? Have you perceived significant differences in the involvement, motivation of staff towards lean projects in these two types of hospitals? So Guilherme, your study that you presented, was there, did you manage to, it was into Healthcare 4.0. Did you find some differences between public and private sector hospitals in terms of their engagement in lean projects?
I think that there is, especially because whenever we are talking about either whichever kind of improvement program, there are some drivers, and the most common one is cost reduction and productivity improvement and so on. And because public hospitals, most of the times they are financially supported by the government, they are concerned regarding cost reduction is not the same as the ones that are private, right? So that need to be profitable and so on. So my belief is that, my understanding is that private institutions are more likely to push these improvement approaches, either lean or healthcare 4.0.
Thank you, Guilherme. Tarcisio, what's your thoughts on that from your experience of engaging with hospital? You're on mute, the most used word since lockdown.
Can you hear me?
Yeah.
No?
Yes, yes. Yeah.
Okay. So I don't have data on this, just some personal experience working with private and public hospitals. But I think that the frontline staff is similarly motivated in both types of institutions. What makes the difference, I think, is the commitment of top management. Especially in private hospitals, top management is more aware of the need for investing in process improvement initiatives. So they usually encourage lower levels and provide the proper resources.
Thank you very much, Tarcisio. That brings us to an interesting question which Professor Diego Tlapa has posted, which is on performance measurements. Is always that dilemma between efficiency and effectiveness. Should I go for waiting time, improve bed availability, or should I be looking for patient and staff satisfaction? And something we have seen in our research as well, majority of the lean study looks into matrix like utilization or access to the services, which is the common lean matrix, while patient and staff satisfactions are scarce. So maybe again, going back to Dr. Sala, what's your thoughts on that? How do you balance that?
I think that in our approach, actually, we look into 4 different voices that need to be heard, okay? And we need to pay a lot of attention. So the first one is what the patient thinks, okay? So patient satisfaction is very, very important to us. The second one is that who's performing the work, okay? It's very, very important, his voice also. The third one is what the process says. So you need to be able to objectively evaluate what the process says. And the fourth one is actually all what is going on is that aligned with the actually true north of the institution. So those 4 voices need to be heard and they need to be combined. But if you ask me, if you have to ask, which one of those might be most important, is the voice of the patient.
Great. I do completely agree with you. If you take care, efficiency will be taken care automatically. Thank you for reinforcing that thought. Rafael, you just dropped. I was going to ask Rafael again a question. Looks like he has dropped out again. Technology playing up, and that's why the healthcare 4.0. We need to have the reliable technology as well, indeed, to get these things going. Again, I would like to ask one question to the panelists here. Lean as a philosophy, it has been applied to all industry. One of the key issues, whether it is healthcare or manufacturing, is the sustainability of lean. And how do you create that long-term sustainability, not just few projects and then the performance fizzles out? So first of all, a short answer, Tarcisio, what do you think? How do you enable lean sustainability in healthcare setting?
Okay, that's one of those $1 million questions. But maybe a short answer is that we should invest on a lean management system, and on developing leadership competencies, people who understand the philosophy and will be able to spread it to others throughout the institution.
Thank you. Guilherme, your thoughts?
I completely agree with Tarcisio, and I would add that the most effective way to influence people is by example, leading by example. And I think this just reinforces what Tarcisio just said regarding developing leadership in healthcare organizations that are focused in such implementation.
Thank you. And coming to Dr. Sala.
I agree 100% with what Tarcisio and Guilherme said. I will also like to add that continuous education is very, very important.
Great. Just a quick question again on we see lean, and we have seen the synergy between lean and healthcare 4.0 technologies, and they're both synergistics. They're both aligned to improving patient satisfaction. Do you see both from academic and the practitioner perspective, we need to reflect on the curriculum that we have got at the university, the syllabus that what we teach our students, the future doctors, the clinicians? Are we teaching the right things to them or something needs to be changed? First, Dr. Sala, your thoughts?
I think that some universities already around the world have been changing and actually adding to their programs in medical schools about lean and process improvement, and that's a big important thing to do. The most important thing also would be right now to add this new 4.0 technology adding to the education. So I think that those are probably approaches that we need to work on to be able to provide the tools right at the medical school. Okay, so before they can become residents and they can work, more efficiently in the future.
Thank you. Guilherme, how you are seeing this trend in Australia? You have recently moved, but any reflection?
Yeah. I would say that those topics are really important to be included in the curriculum. However, my concern is that before those topics are included, I think we still need to work on the horizontal view of processes, especially when we go to areas or fields such as medicine and so on, because this is not a common perspective that we used to explore. So I think this horizontal perspective is the basis for either lean or technology integration. Otherwise, we may be ending in this isolated initiatives that we see quite often.
Thanks, Guilherme. And Tarcísio.
I have a comment which is not a direct response to this point, but maybe it's useful. I think probably the most effective lean healthcare interventions are those in which healthcare practitioners understand the concepts and lead the processes. Us as engineers, managers, experts, and so on, we are only facilitators. But I think it's critical that someone with domain knowledge leads this and knows both sides of the coin, healthcare processes and industrial engineering tools in theory.
Thank you, Tarcísio. You have summarized it. You have nailed it. I would say completely believe if it is led by clinician and supported by other functions, we can see more acceptability, and we can break that resistance to change in healthcare settings, especially if it is led by clinician also. And Dr. Sala has proven it by leading it in his hospital, how important is clinicians. But at the same time, at the university, this is an exemplar, the Heal Me network, where we have got clinicians, where we have got engineers, where we have got people from business school, computer scientists working towards this complex healthcare, socio-technical problems we are trying to resolve from different angle. And that's why we have set up this Heal Me network. We really mean we want to heal healthcare, which has the errors that has plagued for the last several decades. We want to heal that. And one way to do that is to get the practitioners together with multifunctional, cross-functional team of engineers, computer scientists, clinicians, business school people, and other stakeholders. With that, I would like to end this roundtable discussion. I would like to thank all our panelists. Unfortunately, looks like technology is not helping Rafael to get connected. He's not around, but thank you very much, Guilherme, Tarcísio, Dr. Sala, and Rafael for your time. I know, Guilherme, you'd like to sleep now. It's already 2 o'clock there in Australia in the morning, definitely. But thank you very much. This is our first workshop. There are series of workshops planned from here on, where we like to present different perspectives of healthcare management and how we can improve our healthcare system by involving cross-functional team of people. Before I end this workshop today, may I take this opportunity to thank, first of all, Alessandro Macaulay, Professor Alessandro Macaulay, who has been doing all this work. He's the ghost. He's not been seen here, but this event possible, all the hard work that he has put into in getting everybody together. Thank you very much. Professor Diego Tlapa, Dr. Luis Enbed, Daniel Capuro, Roberto Basolo, and Valery Pavlov. Thank you very much for your insights and contribution to make this first Heal Me workshop feasible. You all stay safe, stay healthy, wherever you are. Enjoy the rest of the evening. And if you are going to have the summer break, do enjoy your summer holidays. Thank you very much for joining us today, and hope to see many of you again for the next workshop. Thank you.